Hello, my name is Will Russell, and I'm joined today by Dr. Jim James, who is a former director of the American Medical Association Center for Public Health, Preparedness and Disaster Response. He's the executive director for the Society for Disaster Medicine and Public Health. He's the editor-in-chief of Disaster Medicine and Public Health Preparedness, which is a scholarly journal on public health. He's also a professor at the University of Georgia in humanitarian and global health, and he's also a retired Army general. And Dr. James and I are going to be discussing COVID-19 today, and hopefully going to get some objective information out there for folks. So, Dr. James, how you doing this afternoon, sir?
Very well, Will, and thank you for the opportunity to be here.
Absolutely. So COVID-19 is very divisive, and there's a lot of conflicting evidence about COVID-19 and about how we should be combating it. Why do you think that is?
We have to date over 50,000 scholarly articles that have been published on COVID-19. They support just about any point of view that you can think of. And so it's very easy to come up with conflicting opinion. But beyond all that, there's a basic separation in the medical community between what I would call the clinical community, which defines health in terms of a single patient, if you will, and its physical health. And then you have the population health community, the public health community, which really defines health as physical, mental, economic, and social. So you have one problem, and it's being looked at by well-meaning people from two angles.
So let's talk a little bit about problems with definitions when it comes to COVID-19. What, in your opinion, should be the appropriate definition of a COVID-19 case and why?
The single biggest problem I think we have today is the way it's reported, the way we're defining a case. A case is not a case is not a case. And I think what we have done with COVID-19 as opposed to any other epidemic or outbreak in the past is we're defining it not by its medical definition, which should be disease or injury, but by a lab test. And that lab test shows the presence of a virus. It doesn't show the presence of disease. I think what we should be focusing on are the number of people who get sick from COVID-19. And that's a much, much smaller number than overall case test positives. Just for an example, in this country, we've run something like 50 or 60 million tests to date. Only 10% of those have been positive. And then if you take that 10% that have been positive, only about 50% have ever become clinical. So it's very difficult to say what the medical impact of COVID-19 is when we define it the way we're defining it.
So what about tests? There's been a lot of discussion about various tests, and there's two different types of tests. There's serology, there's PCR. What do you think is going on in the actual testing side of it, and how might that not be giving us the most accurate picture of the virus?
And not to get too technical with this, first of all, you're right, there are two families of tests. But the number of tests, different tests being run within the United States today, at last count for me, was 55. Each of those have different test characteristics, meaning how well they identify people who really have the disease, and also how well they identify people who don't have the disease. Those are the two important characteristics. The other important thing is how prevalent is the infection in the population. If we take what would be considered a good test, 95% capability to get the people truly sick and identify the people who don't have the virus. And we have 5% prevalence, which is 5 times what we see in the national statistics. Then of every 100 people we identify as test positive, only 50 will be true positives.
So are all individuals equally at risk from COVID-19?
I think one of the biggest problems we have, like I said, a case is not a case is not a case for many reasons, some of which we've discovered. The same with risk. We're all at different risk levels. When you talk about risk, you have to look at susceptibility and exposure. I don't think there's any doubt, based on an enormous number of amount of data, that younger people are far less susceptible than older people. I think they are also more resistant to a given exposure level. So that when we are looking at individual people, we can't say that in identical situations, your risk of getting sick is equal to my risk of getting sick.
How do we, or how should public health policy developers be looking at COVID-19 with this risk factor in mind?
That is a very important question. And let's start with at least a philosophy. The job of public health is to assess what risks are and to inform and educate you as to those risks. One of the biggest ones out there is smoking. Smoking has been around for years. It's one of the most risky behaviors I can think of, and it's a perfectly legal thing for you to do. I've done my job. I've told you what the risks are: heart attack, lung cancer, etc. On average, you're going to lose 10 years of life. You make a decision to smoke, you've accepted that risk. Bringing that to one other level, the way individuals evaluate risk in themselves. If I were to ask you, what are you most afraid of? Sharks, snakes, mosquitoes. Everyone's going to say sharks and snakes. Matter of fact, mosquitoes kill 10 times the numbers that succumb to snake bite and shark attack combined. So there's a lot of psychology involved here. Now, when we take that into the COVID-19 arena, again, it's my job to try and point out what the risks are. What are those risks? First of all, they're not equal in the population. The young are at far less risk than the older. People in institutions are far more at risk, certain job occupations. So what's the proper policy? Targeted to the highest risk groups. If we were to really control COVID-19 in the elderly population, we would remove 80% of the lethal outcomes.
So what about the development of a vaccine and also tying in with herd immunity? You have said that herd immunity is not a policy, but how does that tie in again with the development of a vaccine and whether or not we ever will get a vaccine for it?
Let's go a little bit into what we're really talking about here, herd immunity. What you achieve herd immunity at a certain percentage, and let's just say 80%, because that's probably where it needs to be for influenza, or 70%. And that means that in order to stop the virus from being transmitted in the population, you have to have 70 to 80% of your population either recovered from the infection or immunized. They go together, okay? Now, each disease has its own herd immunity level. And most early work with COVID seemed to put it between 60 and 80%. However, that work didn't segment it by risk. Like we said, older people are much, much more at risk. The previous work assumed homogeneity in the population, equal risk. When you adjust for age and activity level, you can come up, and researchers have come up, with herd immunity levels that might be between 20 and 40%. So that part is extremely important with COVID. The other thing is, think of herd immunity the way we think of a campaign where we're trying to collect a certain amount of money, a certain goal, and you reach 5%, 10%, et cetera. Every time you reach a new percentage with COVID, that means that you've decreased the rate of transmission in the population, and you're flattening the curve, which is what we were trying to do in the first place. So with or without a vaccine, eventually, when you've had enough cases, herd immunity, which is a purely natural phenomenon, not an intervention. We're not throwing chickenpox parties and inviting people in to be exposed to a lethal disease. But over time, in the absence of a vaccine, you will reach a point where either transmission is eliminated or it's at such a low level that you can cope with it. And let me give you an example of that real fast. In New York City is not one of the areas where we've seen recent spikes. And if you do prevalence testing in New York, you may come up with levels in the 20% arena, which means they probably have a good protective effect from that herd immunity phenomenon.
So, based on what you've said so far, what is behind the recent spikes in the areas we've seen them in the United States?
I think that's threefold. Let's go back to the 1st of June when, it's kind of the early beginning of the spikes. What happened in early June? We had massive protests all across the United States. Some estimates put the number of participants at 10 million. That means you had 10 million people interacting, close proximity, long period of time. Two saving factors, however. One, it was outdoors, and you get a great dilutional effect when you're outdoors. And number two, they were essentially young people, and young people are going to have a lower attack rate. They're not going to have a zero attack rate. So the first thing is the massive demonstrations and exposures. The second thing, people complain about the level of testing in the U.S. I think we're the number 2 country in the world in terms of doing COVID tests per 1,000 per day. The only country ahead of us right now is Russia. So we have done a lot more testing. When you do a lot more testing, you're going to pick up a lot more people, going back to our numbers, who will test positive but won't be a true positive or may not go on to develop the disease. So we have the population effect from the demonstrations, and we have the testing effect. The third point is they started to occur when the lockdowns were loosened up. And what did people do, especially young families? They went south. The big spikes are in the sun states, the beach states, for lack of a better term. And if you do an interesting analysis of Florida, just to pick out the worst of the examples in terms of the spikes, you see that if you look back in March and April, the average age of the test positive was up around 60. if you look at it today, it's down around 40. And let's go back to what we said in the beginning. A case is not a case is not a case. And therefore, you're going to have far less medical impact. And this shows in the national numbers. If you look from June 1st up to yesterday, looking at 7-day averages, the number of new cases per day has gone up threefold. It's increased 3 times. And if you look at the deaths over the same period of time, 7-day moving average, they've decreased by 15%. So we're seeing different cases, we're seeing a testing effect, and we're seeing a population exposure effect.
Will we get a COVID-19 vaccine?
I think that's a really crucial question that relates to what we were talking about with herd immunity and to other interventions that we may have to do till one is available. The problem with vaccines, and I'll just use the one thing that, 40 years ago we had another really lethal pandemic. That was AIDS, HIV, and to date, we still have no vaccine. So there's a lot of promise for a vaccine, but even if it's fulfilled, there are several problems. Number one, I don't see how we could be ready within a year to 2 years to really have a vaccine ready for injection. Even if we do, the front-running vaccines that I have seen, they require double dosing. So each individual to get a protective immunity needs 2 doses. That becomes a really problem with the elderly, which, like we said, is the high-risk group. And they are the least responsive to a vaccine because they have weakened immune systems just by a factor of age. And then the final piece is more and more surveys are showing reluctance on the part of individuals to even take a vaccine when it's available over safety and other concerns. And I've seen surveys, especially between lower socioeconomic groups, that up to 50% don't plan to take the vaccine.
So masks. So masks are a very hot button issue right now. A lot of states have been mandating them, and governor after governor and even presidents and high up officials are saying, masks are how we will slow the spread. What is your opinion on masks and their efficacy?
Masks will continue to be what you call a hot button issue because there's no real clear answer. You can't sit back and say, yes, masks work, no, masks don't work. It goes back to the risk thing. It's a probability, and it varies with the situation. Now, why don't we start with the situations where masks are definitely indicated? And that would certainly be anybody who's got an upper respiratory infection. You don't have to diagnose it as COVID. If they have an upper respiratory infection, they should stay home, stay away from work, and stay away from people. If they have to go out, if they have to be at work, they definitely need to wear a mask. Why? Because respiratory pathogens are spread in droplets and aerosols. A good mask will absorb a certain amount of that aerosol, etc., and you'll have fewer virus particles in the environment, if you will. That is especially true indoors. The second group where I think masks are indicated is that indoors. If you're in a church, a party, a wedding, any group meeting indoors, I think it's wise to wear a mask. It's a barrier. You'll get some filtering effect. Will it be 100%? No. Why won't it be 100%? Think of trying to keep mosquitoes out with a chain link fence. Uh, it, there are literally, thousands of virins out there, and they're extremely small, and the filter capability just isn't going to do that. A final personal thing is outdoors, and that's where things really become equivocal. I think the 6 to 10 foot rule for social distancing is wise. Whether somebody not wearing a mask is really in danger in an outdoor environment of picking up a certain viral load, I think that's a very low risk. The problem becomes, I don't know everyone who's spreading virus. You don't have to be sick to spread virus. Most studies seem to indicate that 1 or 2 days prior to clinical signs, if you're positive for the virus, you can potentially spread. And if that's the case, then you can theoretically be putting other people at risk, which is why indoors, I just don't see a problem, with masks. Outdoors, I have a different problem with, or a different, it's a whole different risk level. I don't think that they're as necessary. The other thing is the type of mask. If you've got an N95, you're getting well fit, you're getting decent protection. Surgical mask, cotton mask. As you keep going down, the protection gets less and less. I was in Walmart's yesterday and just observing, and between 25 and 50%, I wasn't counting, I was just observing, but it was that many people are walking around with the mask with the upper barrier below the nose. That's giving nobody protection one way or the other. If you want an interesting natural statistic, in most countries of the world, the infection rate for males to females is about 2 to 1, like Ireland's 2 to 1, most European countries. I decided to look up what it would be like in Iran, where the women are required, to wear a face covering, and that's the only country I could find where the attack ratio was the same for males and females, which would indicate that at least the hijab isn't giving a lot of protection.
Interesting. So, from a public policy standpoint, how do you think it's wisest to move forward?
That's a difficult question to answer. I'm going to assume that, vaccine is not right around the corner. That's not wishful thinking. I just see too many obstacles to it. I think we have to look at this in the big picture like a war. And in a war, you're going to have casualties. But a war consists of many, many little battles, smaller battles. We have hundreds of counties in this country. They have health departments. They're, I think, the best source to assess their community's risk. And I think they should be empowered to recommend the interventions that they see necessary in their communities if they have activity going on. So the first thing I would do is take the authority from national or state level and put it at the county level. The other thing, and this is just wishful thinking, I think we have to depoliticize it. It's obviously become conservatives versus progressives, no matter what the issue is. But I think there's one issue we can all come together on. We have to come together on. As I mentioned, in a war, you're going to have casualties. who are the true casualties in this war? It's our children. We have taken a full year almost out of the developmental needs of our children. 55 million between kindergarten and 12th grade have suffered, school, social dislocation. I think going forward, whatever protective measures we take, we shouldn't make our children the casualties. I don't think as a nation we can afford to continue with school closures for the population least at risk. And in closing, I would just like to give a quote from Nelson Mandela. There can be no keener revelation of a society's soul than the way in which it treats its children. And I think we need to stop abusing ours.
Dr. James, I appreciate your time today, and appreciate your time as well and the viewing audience.
Thank you.